Good afternoon, one and all. I'll be talking about DALK in complicated and extreme situation. So let's start with the first situations. Which are the situations which can arise? So sometime they can be related to pre-op condition of the cornea. As you can see from this case, this was a perforated descemetocele which was due to herpes simplex viral keratitis. When I saw, there was no obvious infiltrate there, but there was a large perforation which was there. So I decided to do a DALK there. The perforation was large enough and I was a little concerned that how it's going to plan out. But as it was something which possibly had left rest of the cornea uninvolved, I thought of trying out DALK there. I did not try to bear the descent membrane there. Basically, you want to do a deep DALK there, and as the residual bed was not deep enough, I had to thin out the donor cornea there. The surgery was good enough, and then after putting the suture, 8 sutures, I put air bubble inside and remove all the anterior synechia, whatever was there. Post-operatively, well, patient thankfully didn't have double anterior chamber, and last follow-up patient did very well and had vision almost 6-12 parts. Remember, we could have had a full thickness graft with possible all the chances of rejection and everything. So doing a DALK in such kind of situation still can work. The other pre-op situation which can be complicated is keratoglobus. These kind of thin cornea can be quite bad. Well, what I'm doing here is I'm trying to save the limbal palisades there, so I'm removing the limbal palisades, pushing the conjunctiva back, and then manually deepening the marking which I made with mitrifine. Again, we made a pocket there, and it's a tuck-in DALK, so we made a pocket, and of course we are not bearing the descent membrane here, and we are going deep DALK. I do a little modification there. I try to use almost same thickness corneoscleral rim there, just thin out small amount of sclera from the periphery. And then after putting 8 suture, you can start tucking in the cornea, and which ultimately goes inside quite nicely. Once you tuck in all the cornea and put all the sutures in place, then possibly it's the time to replace your limbal palisade which you had displaced earlier. What it does is it prevents any chances of epithelial healing related issues, and ultimately you end up having a significantly decent outcome. Thankfully, post-op patient had an excellent visual as well as the optical outcome. Another complicated situation can be ocular surface related. As you can see from here, really bad ocular surface with bad symblepharon, all those things. Very thin cornea, and had to confirm that there was a cornea available there. Please make sure that you do an AIOC2024 to make sure what lies behind that pannus. So I planned 3-step procedure. The first step was symblepharon release and pannus resection with oral mucous membrane graft, DALK, and amniotic membrane. And the second step was slit from the other eye, and third step PKP. So the first step, what we are showing here, as you see, then these kind of advanced surface related damage, you can't put a speculum. So I put a lid suture first. I'm trying to save the pannus tissue here, which I could use to form my fornix there. So I'm not sacrificing the symblepharon tissue there. I removed all the fibrovascular scarring, and now I put the speculum. Now that pushes my pannus tissue in the periphery. I'm taking oral mucous membrane here, and after thinning it out, I place this oral mucous membrane on the surface, and I'm trying to use this oral mucous membrane on peripheral bulbar conjunctiva to prevent any symblepharon occurring there. Remember, my goal is not to regenerate the ocular surface here. My goal is to make the way for the future surgery where I am going to do slit from the other eye. Post this thing, I did an amniotic membrane on top of them, an overlay on top of this. Patient did well and underwent all 3 steps and had an excellent visual outcome. Sometimes the factors can be intraoperative. Now here intraoperative factors can be many of them. Many times, in fact, every step of DALK, big bubble DALK, you have potential of perforation there. Maybe the beginning where you are just trying to deepen the groove and you can have perforation, you can simply take suture. Or sometime if you are not lucky enough, then your trephination can end up having perforation. As you can see from here, I had a new trephine in my hand and I ended up having a very large perforation, which was almost more than 200 degree perforation. These kind of perforation are difficult to deal with. You may want to convert to PKP, but what I thought was, as it was not complete, I put 3 stay sutures in the area of the perforation, where the opposite area, which was still intact, I started doing dissection from there. Left behind some small attached area here, and then put the donor tissue there, leaving behind the sutures which I had taken, and finally the last suture, 12 o'clock, I took a full thickness bite there to include my recipient which was there, put an air bubble, and I was concerned about double anterior chamber. Thankfully, there was no double anterior chamber, patient did well, and I could do a DALK there. Sometimes we hear these unique pop sound where we are doing a big bubble DALK, you are injecting the big bubble and big bubble gives away and you end up having a pop sound. So one such case, well, I was making a groove there on the cornea, and then once the groove is made, I decided to make the big bubble there. I don't know whether you can hear it, but yeah, the video has a pop there, and I heard the pop and I knew that, okay, it's gone. You could also see the multiple bubbles in anterior chamber. I had 2 choices, either I convert to PKP, or we know that hydrops cornea also, they hold the descent membrane. Descent membrane does not go away. So I decided to go manually in deepening the dissection, and I could still see the gap there. And thankfully I could salvage my graft and I could do a DALK. Interestingly, that area remained a little bit scarred, and patient could achieve 612, but patient was still happy. In hindsight, when I seen AIOC2024, there was a scar which was deep enough, I should have avoided DALK. So DALK can safely be performed in complicated and extreme situation. Different steps of DALK can lead to perforation, but most of the time you may be able to salvage these cases. Thank you very much.
Yeah. Thank you, Dr. Himanshu, for those brilliant videos and talk and tips. I would like a comment from the panel members.
I think it was a very good collection of difficult cases, and congratulations, you managed it well. So, although I know that when you're having a big giant tear, and this is a phakic eye, and you place the air or gas into the air bubble, so at least in my hands, it's not infrequently to expect Urit-Zavalia syndrome because of the pressure. So any special comments on that? How would you avoid this issue that is not infrequent in this case?
Sure. So that's an excellent question. Thankfully, because of DMEC and DSEX, we have got brave enough to now leave the entire chamber air bubble. Usually what I do is I keep the full air bubble for a couple of hours, and then I deflate it on slit lamp or in OR, make it to the level where the air bubble is free enough and it's not stable. Of course, there are chances that you may end up in a pupillary glaucoma there. Have to be aware of this thing. But thankfully, with our understanding, we know that most of the time we are fine. The other thing is, when the intraocular pressure is high, the bubble falsely shows as smaller because the air gets compressed inside. So it's very important to make sure the intraocular pressure is reduced when you are deflating the bubble, and make sure the bubble is mobile. And I think we should be fine.
You do peripheral iridectomy or not?
In most of the cases, yes, I do. In this case, no, I didn't.